Hi, good afternoon, all. I'm seeing for all classes, I've always seen Priya and Ram, like they have been regular students. Thank you so much for attending it regularly. So, today we'll be discussing about the part of the nephrology, urology part, that is the urinary tract infection. Being an ICU physician, for us, urosepsis, how to manage a sepsis, and the complicated UTIs, knowing about that plays a major role. The simple UTI definitions are towards the OPD spectrum. Okay. But you have to know what is a complicated and an uncomplicated UTI, and what are the changes evolved in the guidelines regarding the definitions. And specifically, you have to know about how to manage the pyelonephritis, especially emphysematous pyelonephritis, and when to opt for a surgical option when it comes to a urinary tract infection. So these are the important topics in urosepsis, apart from sepsis management, which is the common sepsis management, which we all know as per the guidelines. So we'll be discussing about the simple definitions of the UTA as per the guidelines, and then we'll touch upon emphysematous pyelonephritis, what are the grades and how to manage that. Okay, so let us go into the topic, that is urinary tract infection. What is a urosepsis or a urinary tract infection? It is a plethora of infectious symptoms of the urinary tract, starting from the urethra to the kidney, lower to the upper urinary tract, with the wide spectrum of presentation. They can have lower urinary tract symptoms like dysuria, frequency, urgency, or they can have systemic signs and symptoms like fever, sores, and mods, and non-specific symptoms also, nausea and malaise. This is the simple definition of urinary tract infection. What are the risk factors for the UTI? Infants, because they tend to have abnormal urinary tracts or anomalous urinary tracts, or not fully grown urinary tracts, skin related infections, and geriatric and frail patients, and anatomic or functional abnormalities of the urinary tract can lead to recurrent UTIs. Any presence of indwelling urinary catheters, or any obstructions because of stones, staghorn stones causing obstructive uropathy, and immunocompromised state, post-void residual volume, neurological patients who tend to have end up with urinary tract, the Foley's catheter for a long time, and antibiotic usage in the past, resistant organisms, obstruction, and male sex, especially when it involves prostatitis with the involvement of the prostate, and female sex, especially when it is related to pregnancy and pelvic organ prolapse, and recent instrumentation. Basically, when you take gender, male sex, any types of UTI with a prostate involvement, female, pregnancy related, any instrumentation or indwelling catheter, and elderly age, and immunocompromised age, and infants. These are the general risk factors. And when it comes to the history, if the patient had had recurrent UTI with MDR organisms or non-resolving UTI with the resistant organisms, then they tend to develop recurrent UTIs. So these are the risk factors for urinary tract infection. So when you see guidelines, like for anything we follow guideline. So there are three different guidelines. One is the European guideline, one is the American guideline, and there is a Canadian guideline, where European and American is the one which we commonly refer and treat the patients, even at the OPD spectrum or in the inpatient spectrum. So when it comes to IDSA, there was a guideline released in 2023. Okay. When it comes to European, there was one in 2023 and one revised in 2025. Canadian, I'm not very sure. I could not get it, but IDSA and the European are the ones which we are concentrating. So in the older guidelines, meaning starting from 2023 to up to 2024, okay, what all the guidelines said is that UTI can be classified into complicated and uncomplicated UTI, and any UTI in a men and a pregnant woman is considered to be a complicated UTI, and any UTI related to a structural abnormality like an anatomical abnormality in the urinary tract or with an indwelling catheter presence is considered to be complicated UTI. Okay, so now in 2025, IDSA has released one complicated UTI guideline for the treatment, recommendations for the treatment. European has released its official guidelines in 2025. So what changed? Like recently between 2023 to 2024 only guidelines have been released. And what changed in 2025? So both the guidelines, both the European as well as the IDSA, had divided the UTI into complicated and uncomplicated UTI, where uncomplicated UTI can happen in men also. That is one of the important difference that has been suggested by the IDSA. Previously, it was female oriented and they said all men UTI are complicated. Now there is a change with the definition. Like one is that men can also have uncomplicated UTI. And the definition per se, what is an uncomplicated UTI? Any UTI which is present in the bladder, like in the lower urinary tract, is considered to be uncomplicated UTI. Any UTI which is going above the bladder, like kidney, pyelonephritis, or prostatitis, or causing systemic manifestations like causing bacteremia, like pyonia, like that, is considered to be complicated UTI. Okay. So uncomplicated UTI is anything which is restricted to the bladder. Complicated UTI is anything that is above the bladder. That's all. The definition has become very simple. And the additional point is uncomplicated UTI can happen in men also if they don't have any prostatitis, if they don't have any systemic symptoms. These are the two major changes with respect to definitions and the involvement of the men into the uncomplicated UTI. Okay, let us briefly discuss the table. When you can see the older guidelines, the IDSA and the European guidelines, they defined complicated UTI as urinary symptoms plus functional or structural abnormalities of the urinary tract, where patient must have pain, tenderness with fever. That is with respect to complicated UTI when it came to IDSA. And the European said, like any UTI with dysuria, urgency, frequency, flank pain, costovertebral angle tenderness, suprapubic pain, fever, chills, nausea, vomiting, involving anatomical and functional abnormalities of the urinary tract, with the incomplete voiding due to the detrusor muscle dysfunction, in the presence of diabetes and immunosuppression, are all considered to be complicated UTI. But an uncomplicated UTI turned out to be in a women with a normal genitourinary tract. Okay. And even with the European guidelines, they have told that in the absence of any structural abnormalities of the urinary tract, if the patient is having UTI symptoms, it is defined as uncomplicated UTI. This is all with respect to 2023 and 2024 guidelines. In 2025, okay, the recent guidelines says uncomplicated UTI means any infection that is narrowed down to the bladder, and complicated UTI means any infection beyond the bladder. An uncomplicated urinary tract infection can occur in male also, not only in women, it can occur in male also. Okay. I hope the definition is clear. So let us individually see the European as well as the IDSA guideline definitions and go into the topic proper. So the European guidelines has divided the UTI into localized and a systemic UTI, where localized UTI involves the bladder infection, where patient can have frequency, urgency, and suprapubic pain, and they would not have any symptoms of systemic infection, and it applies to all sexes. Okay. What is systemic UTI? If the patient is having fever, chills with costovertebral angle tenderness and bacteremia with the involvement of kidney or prostate along with the underlying risk factor, then it is called systemic UTI. This is with respect to European guidelines. In 2025, this is how they define the UTI. So if you are following a European guideline, if the patient is having only a bladder infection and a localized manifestation, then you call them as localized UTI and treat them OPD wise with the lower antibiotic. If suppose it is a systemic UTI, the patient might end up with SIRS mods and like florid bacteremia and endotoxin release gram-negative bacteremia, where you have to treat the patient with IV antibiotics aggressively, and may plus or minus they may require renal replacement therapy for the renal support. Okay. So what will be the clinical features when it comes to localized UTI? Patient can have dysuria, urgency, frequency, incontinence, urethral purulence, pressure or cramping in the lower abdomen. When it comes to systemic UTI, patient can have fever, hypothermia, rigors, delirium, hypotension, tachycardia, and costovertebral angle pain and tenderness. Okay. This is with respect to European guidelines. Now, with respect to IDSA, as I told you, the old classification had uncomplicated and complicated terms, and the uncomplicated UTI was defined as acute cystitis in afebrile, non-pregnant, premenopausal women with no diabetes or no neurological abnormalities. And acute pyelonephritis was defined as any infection in the kidney, I mean bladder and beyond. And complicated UTIs were all other UTIs. This was the older classification. So what does the new classification in 2025 say with respect to IDSA? Uncomplicated UTI means anything that is confined to the bladder. It can happen in men or women. Okay. And complicated UTI is anything beyond the bladder, like let it be pyelonephritis, let it be a bacteremic UTI, let it be a catheter related UTI. And especially in men, if it involves a prostate infection with prostatitis, then these are all entering into the complicated spectrum. Okay. Why the spectrum is important, we may tend to start up higher antibiotics when the patient presents with like uncomplicated UTI, right? The main goal for this is that to form an antimicrobial stewardship and to like diligently like to use the antibiotics, especially we tend to use this fluoroquinolones and higher antibiotics, even IV antibiotics directly entering into the carbapenems, creating resistance, right? So the main goal of this classification with respect to both the guidelines is to avoid this resistant patterns and to be mindful when you start an antibiotic. Just divide them, see the underlying risk factor, and then you start the antibiotic with a lower to higher. Then it makes sense with respect to treatment as well as in the upcoming resistant patterns, right? And there is another definition called asymptomatic bacteriuria, which is common with both the guidelines, where the patient tend to have bacteria in the urine when you test it, but they may not have any clinical manifestations. Such patients we don't usually see in ICU, but when you put a catheter and you send a urine routine after 2-3 days, yeah, these patients tend to have asymptomatic bacteriuria. Why you have to know this? If there are no symptoms, if you see the bacteria in the urine, you don't get to treat it with an antibiotic unless they have symptoms or a systemic manifestation. You don't have to treat the asymptomatic bacteriuria. All you have to do is be careful and keep monitoring them whether they fall into the sepsis spectrum. Okay, so what is asymptomatic bacteriuria? Even in the OPD or with the catheter related, whenever there is a presence of more than or equal to 10 power 5 colony forming units bacteria in urine without the signs and symptoms of UTI. But in COTI, now it is recently revised as more than 10 power 3 colony forming units. We will discuss this in the upcoming slides. Okay. So in general, what is asymptomatic bacteriuria? When the patient does not have any symptoms and their urine routine shows more than 10 power 5 colony forming units. Urine culture shows so much of bacteria. In women, you have to do check 2 consecutive specimens. In men, you have to use 1 specimen. Okay. They will not have any clinical features. Who are all tend to get such a spectrum? Elderly women, diabetes, pregnancy, renal transplant, any spinal cord injury, catheterization, institutionalization. These are all some of the population who could get asymptomatic bacteriuria only if the patient is pregnant or you are going to subject the patient to any urological procedure, because the chances of mucosal trauma and bleeding is common, right? So only in this two category, you're going to start treatment for asymptomatic bacteriuria. Otherwise, you should not treat the asymptomatic bacteriuria. Unnecessarily, you are creating resistance to the patient. So do not treat if the patient is not pregnant, not a diabetic, like not an elderly, not catheterized, not a renal transplant patient. Just don't treat. Even if they are renal transplant patient, even if they have catheterization, elderly diabetics, don't treat them unless they have a florid symptomatology or a systemic manifestation. Okay. And treatment regimen, if suppose you're going to treat in a pregnant patient, then you can use nitrofurantoin, fosfomycin, amoxiclav for 3 to 7 days. And urological procedure also same antibiotic, I'll tell in the next slide, but shorter course. Okay. And don't use a nitrofurantoin or a fosfomycin if it is turned out to be pyelonephritis. Okay. And screening, you usually we see, right, in OPDs, in gynecology OPDs, we screen the pregnant patient in the first antenatal visit. That is when we tend to get these patients with asymptomatic bacteriuria. That is when you have to screen them also. And if suppose you're going to subject a patient to a urological procedure, then before the urological procedure, you tend to like send a urine sample for a bacteriuria. So as I told you, in pregnant women, you can use nitrofurantoin 100 mg orally twice daily for 5 to 7 days. Fosfomycin, you can give 3 grams as a single dose. Amoxiclav, you can use 3 times a day for 3 to 7 days. Avoid fluoroquinolones and tetracyclines. And in with respect to urological procedure, you can use a short-term antibiotic course like cefuroxime, ciprofloxacin, and Septran. A short-term, like 1 to 3 days course is enough for such patients. Okay. Coming on to IDSA definitions, the uncomplicated UTI and complicated UTI. So the questions could be define complicated, uncomplicated UTI, and how will you manage a complicated UTI? It could be like that. Okay. So how are we defining an uncomplicated UTI when it comes to American definition? A clinical syndrome characterized by local bladder signs and symptoms such as dysuria, urgency, frequency, and suprapubic pain. An uncomplicated UTI is presumed to be confined to the bladder, and it is defined by absence of signs or symptoms which suggest an infection extending beyond the bladder. No fever unless explained by a non-UTI cause, no other signs and symptoms of systemic illness, no flank pain, and no costovertebral angle tenderness. When you define an uncomplicated UTI, patient should not have any of these symptoms. Okay, they should have only local symptoms like dysuria, urgency, frequency, and suprapubic pain. As we discussed, uncomplicated UTI can be present in both males and females, even with underlying urological abnormality, but not very complicated. Even in an immunocompromised patient, when it is confined to the bladder, even in patients with diabetes and transplant, when it is confined to the bladder. Okay, so patients who have indwelling catheter, stents, and percutaneous nephrostomy tubes will not be included under uncomplicated UTI, and especially patients of men who are having prostatitis, epididymitis, orchitis will not be included under uncomplicated UTI. Only cystitis related symptoms in men or women, even with underlying risk factors like diabetes, immunosuppression, transplant, and all of that, when the infection is confined to the bladder, then it is called as uncomplicated UTI. What are the common organisms? As we all know, it is E. coli is the most common organism. Staphylococcus, Proteus, Klebsiella, Enterococcus are some of the other organisms which could be seen with respect to uncomplicated UTI. When you're going to investigate a patient with an UTI, not only uncomplicated, even for a complicated, I'm telling, like there are some urine routine tests which we commonly see in the paper, like from the laboratory. So how specific they are, how sensitive they are, right? So you commonly see this leukocyte esterase test, which is specific only like 40 to 80%, right? It is more sensitive. So when you see a urine routine report with a positive leukocyte esterase, then maybe urine culture and further testing might be more useful than believing this leukocyte esterase alone, because it's less specific. When you see nitrate, it is more specific for the UTI. And when you see microscopy, when the bacteria presence is around 400, I mean the polymorphs presence are around 400 WBC per microliter, then it is more specific. The lesser counts, you have to see the underlying clinical scenario, whether the patient is on catheter, whether the patient has collected the urine properly, it's a contaminated sample. So when the polymorphs are more than 400, then it is more specific. When you come to imaging, ultrasound is only 56% specific, but CT and MRI are more specific. So when you see the investigation and interpret, you see what is more specific and use that as a defining criteria for the UTI. So how will you investigate an uncomplicated UTI? Urine analysis is more than enough, but leukocyte esterase, nitrate and all need not be present. Like just testing a urine analysis with looking for the polymorphs is enough. Even if you don't do that, that is all right. Because patients are typically presenting with dysuria, suprapubic pain. When they have typical symptoms of uncomplicated UTI or a bladder infection, then you can directly go and treat. Okay. Urine analysis, baseline urine analysis is more than enough. You need not subject them to a major imaging like ultrasound, CT scan, MRI and all if they are presenting with uncomplicated UTI. Even urine culture is not necessary if the patient is presenting to you as a first time presentation, then you need not subject them to urine culture also. So when will you send a urine culture? If the patient is presenting to you with recurrent symptoms and atypical presentation, like there is a past history of urological abnormalities or a pregnancy, then you subject the patient to urine culture culture. Then if the patient is immunocompromised, like a malignancy or a transplant patient, then you subject a patient for urine culture. Otherwise, in a healthy patient, men or a woman who comes to you with a simple UTI, you need not send urine culture or major imaging testing. You can just start the treatment. But they present to you recurrently or underlying pregnancy, immunocompromised status, then you subject the patient for urine culture. Okay. Be mindful when you start antibiotics for uncomplicated UTI. Don't immediately start higher carbapenems, that is not needed. You can start with a simple nitrofurantoin when the infection is localized to the bladder. 100 mg BD for 5 days is more than enough. Or if the patient is coming on a OPD basis, you can start Septran also for 3 days. Okay, if the resistance in the local antibiogram is less than 20%. And you can also try fosfomycin 3 gram as a single dose. Okay, second line options, fluoroquinolones. Always keep the fluoroquinolones like as a last resort. Okay, comes to uncomplicated UTI, because the resistant rates as well as the complications related to the fluoroquinolones and tubercular predominance in the India, all that like make us think once or twice when you start fluoroquinolone for a UTI patient. Okay, so always keep fluoroquinolone as a second line when the first line doesn't work. Okay, you can also use beta lactams, but may not be effective when it comes to cystitis. Nitrofurantoin, phospho, and Septran forms the major choice. Okay. Similarly, with respect to European guidelines, they also suggest this nitrofurantoin, pivmesilinam, fosfomycin, and Septran. This pivmesilinam is one of the beta-lactam antibiotic with the same penicillin binding protein mechanism of action only. There is an active moiety called mesilinam, I believe. I don't remember the exact name. It's a mesilinam, where it is a beta-lactam antibiotic. Okay. And again, fluoroquinolone, try not to start as an initial method. Only in the last resort, you start fluoroquinolone. So overall ideology from both the guidelines, you start nitrofurantoin, Septron, or fosfomycin. And European, you have an additional agent called pivmesilinam. If this doesn't work, then you go to the fluoroquinolones. Okay. And don't start IV antibiotics or a higher antibiotics when you're suspecting only uncomplicated UTI. Okay. IV antibiotics only if the patient is unable to tolerate the oral therapy, or if the patient is deteriorating even after starting oral antibiotics, or if the patient is having gross immunosuppression and pregnancy with the UTI and the systemic sign, or the patient is in florid sepsis, that is when you start IV antibiotic. So what are all the choices? You can start baseline ceftriaxone if the patient is stable, there is no ESBL organism, then you can start with ceftriaxone. If the patient is having ESBL or with the carbapenem, then you can start with ertapenem or meropenem. You can also use cefepime as a carbapenem sparing agent. If it is not an ESBL, you can also try piptas. And gentamicin and amikacin only if synergy is reported from the lab, that synergy is reported with the beta lactam, then you start aminoglycoside. If not, basic ceftriaxone. If ESBL, carbapenems. If carbapenem sparing you are using, then cefepime. And only if synergy is reported, then you can start with gentamicin. If carbapenemase producing organisms are there, then you can switch to the newer antibiotics, which I will be discussing in the later slides. Okay. Surgical options for an uncomplicated UTI, it's a no-no. You need not subject them for a cystoscopy, ultrasound, or any anatomical evaluation. Unnecessarily, it's not needed. When they are presenting to you recurrently, then you can refer to a urology and you can do the ultrasound voiding test and urodynamic studies if indicated. Okay, surgery only if there is an obstruction or something is grossly abnormal with the urological tract, like an anatomical abnormality. Unless otherwise it is there, surgical interventions are not indicated for uncomplicated UTI. So, and follow up, usually you can ask them to follow if the patient is pregnant, immunocompromised, or a transplant patient, or some manipulation has been done with the urological tract. Otherwise, you can just start the antibiotic for 5 to 7 days, and unless symptoms are there, they need not have a follow up with the urine culture and all. Okay. So overall, with an uncomplicated UTI, we saw the definition that the infection is localized to the bladder and it can be seen in both men and women. Even in diabetic immunosuppression urological abnormalities, this bladder infection could be seen as uncomplicated UTI. And you start with a baseline oral antibiotic like Septran, fosfomycin, and this pevminicillam. As per European guidelines, you can start Septran. Only these. and fluoroquinolones as a last resort. And if this doesn't work, the patient is crashing, then you can switch to IV oral therapy. And follow up and surgical intervention is not needed. Even urine culture and subjecting them to a major imaging modalities is not needed when it comes to uncomplicated UTI, unless they fall into the spectrum of complicated UTI. Okay. Now, coming on to complicated UTI. How does the IDSA define complicated UTI? A complicated UTI is accompanied by the symptoms which suggest an infection has extended beyond the bladder. The patient will have fever, other systemic signs, flank pain, costovertebral angle tenderness, which was not seen in uncomplicated UTI, right? Pyelonephritis has become a part of the complicated UTI, and COTI, like a patient is on indwelling catheter, that also has come under complicated UTI. And a patient UTI with systemic symptoms associated with transurethral, suprapubic, or intermittent catheterization are all coming under UTI, complicated UTI. Okay. And the patients with complicated UTI may have an catheter, neurogenic bladder, urinary obstruction, urinary retention as an underlying condition. But complicated UTI also includes prostatitis, epidermolysis orchitis, but the treatment is slightly different, and they have given it as a separate section as complicated UTI in men, which we'll be discussing in the later slides. Okay. So complicated UTI, simple, any infection beyond the bladder, and patient will have fever, systemic symptoms, flank pain, costovertebral angle tenderness, and patient will have some of the underlying risk factors like catheter, immunosuppression, and some problems with the anatomical tract. Okay. So when it comes to complicated UTI, urine culture is mandatory. If you feel there is an obstruction, suspected obstruction, you can subject the patient for imaging modality also. And similarly, the common pathogens are E. coli, Klebsiella, Proteus, Pseudomonas, Enterococcus, and in immunocompromised population, you can see Candida also. The main stress is on when you start therapy, see the severity of the illness, see the resistance risk as per your own antibiogram, your hospital antibiogram, see the resistant risk and see the underlying patient factors. What has led the patient to the complicated UTI spectrum? See that underlying factor and mindfully start the antibiotic, because the chances that this complicated UTI recurring is very high. So when you start very higher antibiotics initially, then they may end up with resistance pattern. And nowadays we are already starting ceftazidime avibactam on day one, which may like harm the patient more than help the patient, right? So that is why this approach has been like very importantly stressed in European guidelines. Like when you start an antibiotic, see how severe the patient is, see the resistant risk in your biogram, and see your own antibiogram, like how many patients had E. coli, how many patients had enterococcus, how many patients had MRSA, like BRE. Just see and mindfully start, and also consider the patient factor. Is there anything else you could do for the patient that could prevent the recurrence, like an obstruction or an abnormality or a presence of a catheter? Anything that could like modify your treatment plan. Always keep all of these four factors when you start antibiotics for a patient with a complicated UTI. And the major risk factors, as we already discussed, see the underlying risk factors like catheter use, obstruction, neurogenic bladder, immunosuppression, recent antibiotics and hospitalization, and any male patient with prostatitis, functional anatomical abnormalities, and recent instrumentation, any underlying renal impairment, or all the risk factors. And keep all of these risk factors into your list, whether anything can be modified to help the patient to prevent any recurrence. Okay. And when you start treatment for complicated UTI, you have to start a longer course. Like we saw in uncomplicated, if the patient is going for a urological procedure, you are only going to give for 1 to 3 days. If the patient is a pregnant patient, you're only going to continue for 3 to 5 days. But when it comes to complicated UTI, you have to cover adequately for an adequate time frame, that is at least 7 to 14 days. Like usually you can stop by 7 to 10 days. But if the patient is having pyelonephritis or instrumentation, or you have to relieve the obstruction, then you have to continue the antibiotic for at least 14 days. And when to taper the antibiotic. If the patient is not having major pyelonephritis instrumentation, then you can stop by 7 to 10 days. At least the patient should be afebrile for 48 hours. But if pyelonephritis, the guidelines suggest to continue for 14 days at least. Okay. So what are the common antibiotics we can use for complicated UTIs? As we already discussed, ceftriaxone. If the patient does not have any major ESBL risks, piperacillin tazobactam. And if you are planning for a carbapenem sparing agent, then cefepime. Carbapenems, if the patient is having ESBL organism, you can prefer ertapenem and meropenem based on the resistant risk in your biogram. Fluoroquinolones as a last resort here also. And yeah, Septran, if suppose the patient organism is susceptible to the cotrimoxazole, and aminoglycosides only if the patient is having synergy with the beta lactams. Okay, that you can check with your lab based on their resistance assessment. You can check with your lab, because aminoglycosides itself can have complications like a renal injury and further complications. So unless indicated, you need not start it. You can be confined with ceftriaxone, piptas, carbapenem, cefepime, and fluoroquinolones as a last resort. Okay. And cefepime, when to start? If you feel the patient is not like a high risk patient, not entered into shock, but inpatient, you want to spare the carbapenems, then you can start cefepime. But if the patient is already into florid sepsis, septic shock, and patient is having pyelonephritis or recent instrumentation, then you can directly start meropenem into the spectrum, seeing your antibiogram. Okay. Surgical intervention might be important when it comes to complicated UTI. If the patient is having obstructive uropathy, worsening the situation, until unless you drain the source of sepsis, the patient will not recover. Even if you give ceftazidime-avibactam, or even if you give ertapenem initially, patient may not recover unless you remove the source of sepsis, right? So you have to see the underlying risk factors. What is leading the patient to the complicated UTI? Like among the 4 points we discussed, what is leading to the complicated UTI? You have to see if the patient is having obstruction, urgent decompression or a DJ stenting might be required. If the patient is having an indwelling catheter with the systemic symptoms, then a catheter replacement and sending a new culture from the catheter might be warranted. And if the patient is having prostatic abscess, especially men having prostatic abscess, very important, you have to immediately give urology referral. Like how important is fournias gangrene to be debrided, that important is prostatitis in men, where you have to immediately subject them for drainage of the abscess. Unless until you do that, the patient will not recover whatever antibiotic you give. Okay. And if the patient is having hydronephrosis, then dilatation or stent placement may be required. If the patient is having emphysematous pyelonephritis, based on the grading, like 1, 2, 3A, 3B, and 4, based on the grading, the patient may require percutaneous nephrostomy or even nephrectomy. If suppose fungal infection is suspected, then you have to start them on antifungal therapy. Okay. In complicated UTI, any obstruction, any catheter, especially prostatic abscess in men, and emphysematous pyelonephritis in patients with risk factors, they may warrant urgent surgical intervention. Until unless you do that, the patient will not recover. Okay. Coming on to one of the complicated UTI, that is catheter associated urinary tract infection, which is the commonest scenario which we will see in our ICU. So when patient is having signs and symptoms of UTI in the presence of an indwelling urinary catheter, or who had a catheter removed within the previous 48 hours. So the catheter must be there at least for 48 hours, or it must be just recently removed within the 48 hours. If the patient is having signs and symptoms of UTI, then it is called catheter associated urinary tract infection. So how are we going to confirm? The patient should have, when you test the urine, the patient should have more than or equal to 10 power 3 colony forming units of at least one bacteria or more than one bacteria in a urine specimen collected aseptically, preferably obtained after the catheter replacement, and absence of alternative source of infection. When you define a COTI, you have to tell the patient must be on the catheter for 48 hours, or the catheter must have been removed within 48 hours. Along with, the patient should have more than or equal to 10 power 3 colony forming units of one bacteria or more than one bacteria. And important point is that it should be collected aseptically, more preferably from a newly replaced catheter rather than taking it from the older catheter. I believe in all our hospitals, the infection control team will keep on telling that if the catheter is placed within 48 hours, or if you are sending a urine culture, send it from a replaced catheter. They will be insisting this so strongly, because when you take it from the older catheter, definitely what 10 power 3, the patient will have 10 power 9 colonies also. But when you take it from the new catheter, we can properly define COTI, and we can even modify our antibiotic therapy based on a protocolized approach, right? So the patient should have a catheter for 48 hours. The catheter must be, or if the catheter is removed, it must have been removed within 48 hours. And the patient should have more than 10 power 3 colony forming units of at least one or more bacteria, preferably collected from a replaced catheter. And there shouldn't be any alternative source of infection which is worsening the signs and symptoms apart from the COTI. So you should rule out any alternative diagnosis also. When you have all these 5 points, that is when you define a patient to have COTI. Okay. So the patient can be symptomatic and asymptomatic. So when the patient is having only, you are sending randomly, the patient is having sepsis, you are just sending a urinary analysis just as to see urinary infection is there or not. The patient does not have any major symptoms, then you cannot take that as symptomatic COTI. Okay. Any asymptomatic COTI, you need not treat aggressively. Like you can just keep monitoring the patient and you can just support the patient. If it is a symptomatic COTI, yes, you have to immediately start treatment. The first treatment will be remove the catheter, exchange the catheter, and then based on the organism found, you have to see whether it's an antibacterial or a fungal COTI. Okay. And pyuria alone is not diagnostic of COTI. Catheter colonization without symptoms is not an indication for an antimicrobial treatment. The patient will have symptoms like fever, suprapubic tenderness, costovertebral angle pain, and urinary symptoms in a patient who's on catheter. So when these symptoms are present, then it is called symptomatic COTI, and that is when you start treatment for the patient. If it is an asymptomatic COTI, just replace the catheter and support the patient. That's all. You need not immediately jump on starting higher antibiotics for such patients. Okay. So most common organisms, bacteria and fungus. So bacterial COTI, as per the guidelines, both the guidelines, recent guidelines, when you just see pyuria, that is not diagnostic. When you can find organisms like E. coli, Klebsiella, Pseudomonas, Enterococcus being the common organisms causing COTI. When you find the COTI, symptomatic, asymptomatic, just exchange the catheter. Okay. And when you're sending a culture for a complicated COTI, symptomatic COTI, just always send it from the new catheter. Okay. And when you're giving treatment for a complicated UTI, any complicated UTI, especially COTI, at least continue the treatment for 7 days. If the patient is responding well within 7 days, afebrile for 48 hours, then you can stop the treatment by 7th day. Or if the patient is having persistent symptoms, persistent worsening of the symptoms, then you can continue for 10 to 14 days as per the guidelines. If it is MDR or persistent symptom, you can continue for 10 to 14 days. Okay. So asymptomatic COTI, just change catheter, support. Symptomatic COTI, you treat whichever bacteria is growing, you treat accordingly. If the patient is responding well, you can stop the treatment by 7 days. If the patient is not responding well, you have to continue at least for 10 to 14 days, especially when it comes to MDR organisms. Okay. Coming on to second common organism is fungus. Fungal COTI, the most common organism is Candida. If the patient is having asymptomatic candiduria, like you sent a sample, there is Candida, the patient is not having any symptoms, then you need not jump and start any major antifungal. You can just exchange the catheter and support the patient. Okay. But if the patient is having symptoms like worsening shock or fever, new onset fever, patient is complaining of abdominal pain, if the patient is awakened complaining of abdominal pain or costovertebral tenderness is there, then you have to change the catheter and start antifungal therapy. And when you start antifungal therapy, most of the Candida albicans may be susceptible to fluconazole alone. You can start with azole therapy. If the patient does not respond to the azole therapy, or there is a local fluconazole risk that the patient has had taken fluconazole in the past and now there is resistance risk, then you can switch to liposomal amphotericin or echinocandins. Actually, echinocandins have very poor urinary penetrance. So when you started for an uncomplicated UTI or an asymptomatic UTI or UTI without a bacteremia, echinocandins may not play a major role. I mean, fungemia may not play a major role. When the patient is having systemic signs and symptoms and fungemia is also there, then echinocandins candidemia is there, then echinocandins may help. But always keep fluconazole as a first choice, because most of the albicans candida will respond to fluconazole. But when it is candida cruzae, oris, or a non-albicans candida, then you can switch to liposomal amphotericin B. If there is systemic candidemia, fungemia, then you can try echinocandins also. Okay. And if the patient is having any obstruction or fungal bizarre formation, then whatever you treat with antifungal, the patient may not respond. You have to subject them to the urological procedure to relieve that obstruction and removal of the fungal bizarre. That is when they may respond to the antifungal therapy. Okay. So there are so many bundles, like with respect to various guidelines, CDC, IDSA. So there was one sensible guideline which I found from a review article, practically applicable for all our ICUs. If needed, you put catheter. If you put catheter, try to keep it clean, especially hand hygiene and the meatal and peri care, like perimeatal care and the pericatheter care, very importantly, at least twice a day. Keep it clean. And when you keep the catheter, you secure the catheter so that you reduce too much of the movement and injury to the local structure and secondary biofilm formation and secondary infections. And when you are using, always use a closed system. And when you are draining the urinary catheter, try to keep it low, so that it prevents reflex as well as it drains appropriately. And you send urine culture only if the urine is so turbid in a exchanged catheter, or if the patient is having systemic manifestations like fever, symptoms. That is when you send a urine culture. Simply unnecessarily don't keep sending urine analysis, urine culture when the patient does not have any symptom. Just because catheter was there 48 hours, you need not keep sending surveillance cultures for all immunocompetent patients. In immunocompromised patients, the protocol is different. Like in febrile neutropenic patients, as we discussed, the patient have the patient have recurrent fevers after 48 hours, 72 hours, then you can send. But in an immunocompetent patient, just because you want to see what is growing, that is not needed. Okay. I have worked in ICUs where the consultants, usually some of the consultants, they tend to have this habit of sending cultures for simple things. That is not needed unless you really see the patient is having frank symptoms, or like patient is having severe abdominal pain or a proven obstruction. You need not send cultures. So when you put a catheter, keep it clean, keep it secure, keep it closed, keep it low, and unless indicated, don't send cultures. It is going to cause confusion. If not needed, try to remove the catheter as soon as possible. Okay. This forms an evidence based bundle for prevention of COTI. Okay. So among the complicated UTI, we have discussed one of the UTIs, that is the COTI. We'll be discussing the next complicated UTIs. Okay. And recurrent UTIs. So how do we define recurrent UTIs? Recurrent UTIs are recurrences of either uncomplicated or complicated UTIs. How do you define them? When there are more than 2 episodes of UTI in 6 months, or more than 3 episodes of UTI in 1 year. This is called recurrent UTI. So what are the risk factors for a recurrent UTI? In young population, it could be because of sexual intercourse, use of spermicide, new sexual partners, a mother with a history of UTI, and recurrent history of UTI in the childhood, and a blood group antigen secretory status. So these are all the common risk factors in young population. In post menopausal population and elderly women and elderly male, which we commonly see in the ICU, like history of UTI before menopause, urinary incontinence, atrophic vaginitis due to estrogen deficiency, cystocele, high post-void residual volume, and urinary catheterization or institutionalization. These are all the common risk factors for recurrent UTIs. We do see patients in the ICU with recurrent UTIs. The main problem with that is problem with such a population is that they tend to have complications, like they tend to have reflux and infection spreading up. And number two, they tend to have MDR organisms, because we start IV antibiotics for them thinking it's complicated, and then the resistance develop, and then you keep increasing the antibiotic. Ultimately, we end up with no choice for treating such organisms. So the major problem with the recurrent UTI is antimicrobial therapy. That is why see the underlying risk factor and start sensibly the antibiotics. Okay. And when it comes to recurrent UTI, there are a few definitions. Actually, it doesn't make any major change in the treatment, but you just should know. Okay. What is an unresolved UTI? When there is a treatment failure due to bacterial resistance or due to infection by two different bacteria with equally limited susceptibilities, then the patient can present with recurrent UTIs. And what is a reinfection? The patient has been treated and there is no growth after the treatment. Okay, but again after 2 weeks, okay, the same organism regrows, then you call it as reinfection. Or after 2 weeks of therapy, if a new organism grows, then it is called reinfection. So when it comes to reinfection, the definition is the patient should have received a treatment for 2 weeks, and then you have been declared them negative, and then again a new organism or the same organism is growing, then it is called reinfection. What is a relapse? You are treating a patient with an UTI, not even the 2 weeks is completed, again another organism, the patient is getting infected with another organism. So within 2 weeks of the therapy, if the patient gets another UTI, then it is called relapse. After 2 weeks of therapy, then it is called reinfection. Okay. Coming on to the next complicated UTIs, which we commonly tend to see in the ICUs. One is the pyelonephritis, and among the pyelonephritis, emphysematous pyelonephritis is a very dangerous condition. Unless until you subject the patient for drainage of that particular collection or nephrectomy, the patient may not improve whatever you do. Okay, so pyelonephritis, we know that it is a complicated UTI. It is the bacterial infection involving the renal parenchyma and the pelvis, and the infection might have ascended from the bladder to the kidney, or it could have happened from the hematogenous through the hematogenous spread also. Okay, so usually pyelonephritis tend to happen in patients who do have underlying risk factors. That is most commonly diabetes, immunosuppression, urinary tract manipulation by means of any procedures, instrumentation, catheters, institutionalization, are the common risk factors who tend to get the pyelonephritis. Okay, and the pyelonephritis will present with symptoms like fever, costovertebral angle tenderness, nausea, vomiting, malaise, and associated lower urinary tract symptoms may present, may not be present. If it is present, then maybe the source of sepsis is, the source of infection is from the bladder only. The patient can have abdominal pain and discomfort, and the patient might have a very florid systemic signs like hypotension, tachycardia, altered mental status in severe cases. Okay, as I told you, the common risk factors are anatomical abnormality, diabetes mellitus, because per se hyperglycemia can impair the neutrophil function and can facilitate glycosuria, and immunosuppression, transplant or chemotherapy, corticosteroids, all could make the patient prone for secondary infections. Pregnancy, mainly because of the progesterone induced urethral dilatation and urinary stasis, which could trigger the secondary infection. And recurrent UTI history, indwelling catheter, institutionalizations, and sometimes even genetic predisposition, which may hamper the fighting of the normal mucosal cilia with the bacteria. So all of this could be the important risk factors when a patient gets pyelonephritis. Okay, complications. What are the complications of pyelonephritis? Why it is so serious? It can cause obstruction, it can cause perinephric abscess and worsening of the situation. It can cause emphysematous pyelonephritis. It can cause acute kidney injury, where it may make the patient be make the patient in need of renal replacement therapy. Patient can end up in CKD from acute kidney injury. But usually pyelonephritis do not recur, because when we find a pyelonephritis, we tend to see what is the underlying cause and treat it aggressively. Unless you don't treat it for an appropriate duration, it will not recur most commonly, okay, like a cystitis. Okay, so it could lead to so many complications, especially emphysematous nephritis and acute kidney injury to chronic kidney injury. And that is why treatment of pyelonephritis should be aggressive, and unless until you treat the source of sepsis, the patient may not improve. Okay, and here also the common organisms in young population is E. coli, and we tend to see only the elderly population. Especially it is caused by E. coli, less virulent E. coli strains, gram positive organisms. If it is immunocompromised or catheter related, then fungus is also common, candida is also common, and other gram negative organisms like klebsiella, proteus, and pseudomonas. And important gram positive organism is enterococcus. Okay, and what are the risk factors for multi-drug resistance organisms? We discussed that in complicated UTI, the main problem is that recurrent UTIs, the main problem is that MDR organisms. Who are all the risk of developing MDR UTIs, complicated UTIs? If they had used antimicrobials within the past 3 months, especially fluoroquinolones and anti-pseudomonal penicillins, or there was a history of multi-drug resistant urinary isolate even in the past, or persistent institutionalization or catheterization, or urological abnormalities which has not been surgically repaired. So these are all could be reasons for MDR. That is why when you see an MDR organism or such a complicated UTI, always see what are the underlying factors which you could like treat, so that they don't come back with the same urosepsis and die because the organisms are MDR and the normal antibiotics are not working. Okay, and pyelonephritis can be graded into mild, moderate, and severe according to European classification. Mild pyelonephritis, when they don't have any systemic inflammatory response syndrome, they are hemodynamically stable and tolerating the oral intake. Moderate pyelonephritis, when they have presence of SIRS or hemodynamic instability that require intravenous therapy. And severe pyelonephritis is that patient is into florid sepsis, septic shock, and they have complications like renal perinephric abscess or emphysematous pyelonephritis. Okay, that is how pyelonephritis has been graded into mild, moderate, and severe according to European classification. Coming on to imaging in pyelonephritis, when the patient has mild symptoms, then responding to the therapy, then you need not subject them to repeated image, higher imaging. Even ultrasound abdomen should be enough to diagnose the patient. But when you don't see any clinical improvement in the next 48 to 72 hours, even after appropriate antimicrobial therapy, then you subject the patient to CCT abdomen or MRI as needed. And when a patient is having underlying hyperglycemia, uncontrolled diabetes mellitus, especially men and immunocompromised individuals, then you subject them to imaging. Okay, and when you suspect an obstruction like hydronephrosis and nephrolithiasis, then imaging can be justified. And if the patient is having recurrent pyelonephritis, then imaging can be justified. So what is the conclusion is, you don't directly subject them to higher imaging protocols, which is not needed. If you feel that the patient is having a complicated UTI like a pyelonephritis, like with a simple urine culture and a simple ultrasound, it is diagnosed, well and good. If the patient is having recurrent symptoms with underlying immunocompromised status, with underlying risk factors or urological abnormalities, and especially men, you subject them for higher renal imaging. So renal ultrasonography is more than enough to evaluate for obstruction or abscess. Contrast enhanced CT can be used for recurrent symptoms and for high risk population. Okay. When you see pyelonephritis, it can be graded into grade 1, 2, 3, and 4. When you have a focal wedge-shaped hypodense lesion, then it is grade 1. When you have multifocal lesion, then it is called grade 2. When you have abscesses that can be defined as 2 centimeter, less than 2 centimeter, then it is grade 3. When the abscess is growing beyond 2 centimeter, then it is grade 4. That is how you grade pyelonephritis. So usually we see like perinephric fat stranding, all the inflammatory signs, and local hypotense lesion. But when in severe cases, it could be like this, where it may immediately require any surgical intervention also. Okay. So how are we gonna treat the pyelonephritis? When you see pyelonephritis, IV antibiotic is indicated, especially in men. When you have a complicated UTI, you have to start with IV. Mild to moderate cases, you can start oral antibiotic. I'm talking about the severe IV, but mild to moderate cases, outpatient, you can treat like ciprofloxacin, levofloxacin, cotrimoxazole can be tried. Even baseline beta lactams can be tried. If the patient is having mild to moderate symptoms, you have to continue at least for 7 to 10 days. But most of the patients whom we see in the ICU is in the severe or inpatient category, where you have to start with IV antibiotics. You have to continue for 10 to 14 days. Okay. And once the patient is stable, at least afebrile for 48 hours, then you can even switch the IV antibiotic to oral antibiotic therapy, but you have to continue definitely for 14 days. 10 to 14 days mandatory is very important. Okay. And if suppose the baseline ceftriaxone, cefepime, piptas, carbapenems are not working, meaning it's an MDR, carbapenem is producing organisms, nothing is acceptable, then you can try the newer agents like ceftazidime avibactam can be tried. It is not a newer agent anymore. We have made it old already. So ceftazidime avibactam, ceftriaxone tazobactam, and imipenem vaporobactam, that also can be tried. Meropenem vaporobactam can be tried, and plasomycin can also be tried. These are some of the newer antibiotics which can be tried if the patient is having like XDR, PDR, or if the patient is having carbapenem is producing agent organisms, then you can try some of the newer antibiotics among the list. Okay. And surgery, yes, definitely it is indicated. When you see that is the underlying risk factor, you have to subject the patient to surgery. When there is an obstruction, relieve it. When there is a collection, do a percutaneous nephrostomy and remove it. Remove the abscess, remove the collections, and if there is obstruction, relieve the obstruction. This is very important. Okay. Coming on to emphysematous pyelonephritis. So emphysematous pyelonephritis is nothing but an acute necrotizing infection of the renal parenchyma and the surrounding tissue. Gas may be present in the renal parenchyma in the collecting system or in the perinephric fat. Okay. The most common important risk factor for a patient to develop for emphysematous pyelonephritis, or even for emphysematous any cystitis like cholecystitis and pyelonephritis, any emphysematous changes, is diabetes mellitus. Okay. It can be very common. It's very common in diabetes mellitus patients, and the reported mortality is around 40 to 90%. Okay. When you see the organisms, the common E. coli, Klebsiella, Proteus, Pseudomonas are the common gram-negative organisms, gram-positive Enterococcus, and rarely Candida can also be seen in an immunosuppressed patient state. Okay. What are the risk factors? The most common risk factor is diabetes, obstructive uropathy, urolithiasis, female sex are some of the moderate risk factors. And the risk factors, what are the risk factors for poor outcomes when a patient is having emphysematous pyelonephritis? Advanced age, any systemic manifestations like altered mental status, thrombocytopenia, severe proteinuria, renal failure, hypoalbuminemia, high-grade emphysematous pyelonephritis, polymicrobial infections, and shock. When the patient has one of these or many of these, then the outcome, the prognosis is very poor. Okay. When you see why it is common in diabetic patients, in uncontrolled DM, there is high tissue glucose level and poor tissue oxygenation due to microvascular disease. Okay. This helps bacterial propagation and disease progression. So it will lead to accumulation of the organisms, leading to the production of gases, including hydrogen, carbon dioxide, and nitrogen during the fermentation of glucose and lactate by the microbial organisms. And that is why you see the very important clinical picture that that emphysematous changes or gas. So emphysematous pyelonephritis, like how you grade pyelonephritis, it can also be again graded into 4 grades according to Hong and Seng. Class 1 is gas in the collecting system only. Class 2, it is the gas in the parenchyma. Class 3A, that is extension of the gas into the perinephric spaces. And class 3B, that is the extension of emphysematous changes into the pararenal space. And class 4 is in like the entire kidney is full of emphysematous changes. Okay, that is how you classify the emphysematous pyelonephritis based on Ong and Singh. How are you going to treat the emphysematous pyelonephritis? So the treatment should be, after you stabilize the patient with airway breathing circulation, you have to mainly concentrate on renal salvaging therapy. So the kidney is turning into like balls of gases, right? So you are going to save the kidney which is functioning well, and you're also going to save the part of the kidney which is functioning well. Okay, your goal should be renal salvaging therapy. First, you properly resuscitate the patient to prevent any hypoperfusion, and you treat the sepsis with an appropriate antibiotic to prevent further complications of the infection, and you control the sugar, which is a very important factor. Okay, like you keep the target even lower, like 140 to 180, keep it in the lower end 140. Okay, this common general measures are very important. Okay, and secondly, the local definitive measure. If you find a pus, you drain it. Okay, if you find any obstruction, you relieve it. This too should be the mantra for any pyelonephritis. You find abscess, you drain it, and you find an obstruction, you relieve it. Okay, along with general measure, these two are important. Unless until you do all three, the patient will not recover whatever you do. Okay, so any diabetic patient who have symptoms of pyelonephritis or emphysematous pyelonephritis, you grade them like class 1, 2, 3, 4, right? According to the CT, you are grading them, right? Once you finish the resuscitation, appropriate antibiotic therapy, and glycemic control, you are going to treat the you are going to plan the local therapy based on the class of the emphysematous pyelonephritis. Okay, if the patient is in class 1, like the patient is having only a part of the kidney, a part of the having kidney having gas, then you start with medical management. Okay, if you find any obstruction, you just try to relieve it either by DJ stenting, or if you find any small collection, you drain it with nephrostomy. Until unless there is obstruction or a collection, you need not do anything much for the class 1. You can keep observing the patient. Okay, when it comes to class 2, if less than 50% of the renal parenchyma is involved, then you treat only medical. Okay, but when it is more than 50% of the renal parenchyma involvement, then you subject the patient for percutaneous drainage of the collection. Okay, when the patient is in class 3A and B, along with medical management, along with removal of the obstruction either by means of DJ stenting or removal of the collection by means of percutaneous nephrostomy, always keep a backup of open surgical drainage, because the percutaneous drainage may not be more effective in such patients because the collection is huge. Okay, always keep a backup plan for open surgical drainage. Okay, but when it comes to class 4, the entire kidney is turned into a gas, right? Gas ball. So there is no use of retaining the kidney, and keeping the kidney or a part of the kidney which is grossly damaged is going to complicate necrosis and secondary infections. Then in such cases, you may have to subject the patient for nephrectomy. Okay, so based on the class, you classify into class 1 to 3 based on the CT grades. If it is class 1 and class 2 with less than 50% of involvement, you can still wait and treat the patient medically and try to relieve the obstruction. But if it is class 2 more than 50% and class 3 and class 4, always drain the abscess by PCN and relieve the obstruction by DJ stenting, and keep a backup option for surgical drainage, and always keep a backup option when it comes to class 4 for nephrectomy. Okay, until unless you don't do this, the patient will not recover. Okay, that is why calling the urology, involving the urology, taking the surgical opinion as early as possible is very important in pyelonephritis and emphysematous pyelonephritis when they have higher grades of infection. Okay, coming on to urosepsis. So we saw complicated UTI, we saw uncomplicated UTI, and now coming on to florid sepsis. So sepsis, we know that when there is an altered immune function because of the urinary tract infection that has become complicated, then it is called urosepsis. You treat as per surviving sepsis guidelines like resuscitation, IV fluid, vasopressors, appropriate antibiotics, cultures, and then if needed steroids, and then if needed albumin as a last dot. You just treat accordingly as per the surviving sepsis guidelines, along with relieve the obstruction, remove the collection. Okay, coming on to male UTI. As I told you, both the guidelines, American as well as the European guidelines, have given a chapter called male UTI because the uncomplicated cystitis we can manage, which will not cause any major issue. In other patient like women, elderly patient, like when it comes to pyelonephritis, which is the very important complicated infection, we have seen the management. But when it comes to male, there are important small organs which could worsen the scenario, especially the prostatitis and orchitis, which are all like these are all very small organs. But when it gets infected, the invasiveness as well as the spectrum which the patient is going to face, the men going to face, are very complicated. That is why the male UTI has been given an utmost importance, especially when a man is having prostatitis or an epidermolysis or a Fournier's gangrene or acute or chronic bacterial prostatitis. In such scenarios, you have to involve the urology. You have to drain the prostatic abscess or the prostatic collection, which is worsening the clinical scenario, along with whatever measures we have seen for a general complicated UTI. So all men UTI with a structural abnormality with prostatitis involvement or with genitourinary infection are considered to be complicated, except the uncomplicated simple cystitis, which we discussed in the first few slides. Okay. So, what are the risk factors in men to have UTI or a complicated UTI? When men tend to have a benign prostatic hyperplasia in the elderly ages, where this population forms a major population for the UTI, and the presence of indwelling catheter or a recent catheterization could be an important risk factor. Instrumentation of the urinary tract, like when they have LUTs, like lower urinary tract obstruction, usually we tend to subject them for dynamic studies and cystoscopy, which could be a risk factor for the urinary tract infection, and strictures, which is a very common situation in men. So urethral strictures in elderly age could be a problematic underlying risk factor for the urinary tract infection. Renal stones, and as usual, the common diabetes mellitus immunosuppression risk factors for common UTIs. Okay. And what are the symptoms in men, which is different from the general UTI? Along with the lower urinary tract symptoms, the patient can have perianal pain and painful ejaculation and urinary retention could be additional signs and symptoms when the patient is having a prostatitis. The patient can have scrotal pain and swelling when they have epidermolysis, and in elderly patients they could be asymptomatic also. And especially in a sexually active men, you have to look for any genital ulcers, genital lesions for a sexually transmitted infection, which forms a major part of the UTI in men. Okay. So in ICU, in elderly population, when you suspect UTI or when you see a growth of the organism of more than 10 power 5 colonies or 10 power 3 colonies, you always try to examine the local genital region when it comes to men, because you may miss on this urethral stricture, the prostatic manipulation or enlargement, or the scrotal swelling, like a scrotal swelling, scrotal skin, which we may miss, which we do not, which we don't examine generally, right? So always keep in mind when a male patient is admitted to the ICU, when the patient is having persistent fever or like all the systemic signs and symptoms, and there is a positive growth, just try to see anything which you could do, which could help the patient to remove the source of the sepsis, so that when you give an antibiotic, it will effectively work and support the patient. Okay. Always look at the catheter, the penile region, the like retraction of the skin and the prostatic manipulation and the scrotal skin. Always keep in mind to examine the genital region, especially in men with UTI. Okay. Coming on to antibiotics, both the guidelines suggest that when a male population is having a complicated UTI, most common organisms are the gram-negative organisms. You start with IV therapy. Okay. Ceftriaxone, Piptas, ertapenem, meropenem, fluoroquinolones, as per the biogram. And once you start IV therapy, if the patient is responding well and remaining afebrile for 48 to 72 hours, then you can switch to oral therapy. But you have to continue at least for 14 days. If when it comes to pyelonephritis, you have to continue for 2 to 4 weeks when it comes to prostatitis. And if it is a chronic prostatitis, you have to even continue for 6 weeks. Okay, so always keep in mind when you are treating a male complicated UTI, if the patient is in ICU, you started him on IV therapy, the patient improved, okay, you're going to retriage the patient from ICU to ward. Okay, always make sure you are putting in order that the patient has to continue at least oral antibiotic therapy at least for 2 to 4 weeks in an acute prostatitis patient, at least for 4 to 6 weeks in a chronic prostatitis patient, and if it is a pyelonephritis complicated UTI in a male patient, at least for 14 days, which is a general formula which we applied for other pyelonephritis also. Okay, that is the difference when it comes to male UTI. We tend to miss that prostatitis, other treatable like epididymitis, orchitis, the local infections which could get complicated, which can be easily treated when we involve the urology team. Okay. Surgery, yes, as usual, when you find an obstruction, you relieve it. But when you find a prostatic collection, you involve the urology team, you try to drain as soon as possible. Okay. Any anatomical abnormalities that could be corrected should be corrected. Okay. When it comes to a male complicated UTI, follow-up is mandatory. Especially when you give an antibiotic therapy for 7 to 10 days, you call the patient for a repeat urine culture after 10 days. Okay, because the male UTI organisms tend to get retained into the urinary tract or in the residual volume or in the prostatic tissue. Um, very like often that happens. That is why you have to call the patient for a follow up, especially in a male UTI. At least after 10 days of therapy, you should repeat the urine culture and see any persistence of the organism is there. Okay, and always involve the urology and do appropriate imaging to not to miss out on any complications. Okay, then coming on to other simple male UTIs, that is urethritis. When there is an inflammation and infection of the urethra, then it is urethritis. Always rule out gonorrhea. Okay. So when it comes to treatment of the urethritis, if you confirm gonococcal infection, you can start with ceftriaxone, azithromycin. Alternatively, you can try cefixime. If there is an allergy to the ceftriaxone, then you can try aminoglycosides and fosfomycin. Okay. And doxycycline also. Then non-gonococcal infection, you can start with doxycycline. If not respond, alternatively, you can use azithromycin. If it is chlamydia, then you can start with azithromycin or doxycycline. If no response, then you can keep levoflox, oflox as a secondary agent. If it is mycoplasma, again azithromycin. If not, you can start with moxifloxacin. If it is ureaplasma, urealyticum, doxycycline. If not, azithromycin. If it is trichomonas vaginalis, then you can start with metronidazole, tinidazole. If not, later therapy with metronidazole alone. Then non-gonococcal, we have already seen this. Start with azithromycin. We saw that initial therapy is azithromycin. If there is persistence, then you can add metronidazole to the picture. If azithro was the first line of treatment, then you can switch to moxifloxacin plus metronidazole. Okay. Coming on to prostatitis, we saw the clinical therapy. The common antibiotics which are used are along with the ceftriaxone, carbapenems in the initial phases. You can switch to optimal oral therapy with fluoroquinolones, doxycycline, azithromycin, metronidazole. Okay. Coming on to epididymoarchitis, if you suspect, if there is a torsion suspected, then you have to subject the patient for immediate urological procedure. If there is no torsion, it is only epididymitis, then rule out gonorrhea. If gonorrhea is likely, treat according to the table we discussed before. And if it is gonorrhea unlikely, you can start with common broad spectrum and then taper it according to the culture. And you have to follow up the patient after 7 days, and you have to involve the infection disease control team so that the sexual partners are also involved if gonorrhea is likely. Okay. Coming on to Fournier's gangrene, which is one aggressive like necrotizing fasciitis of the scrotal skin, which could involve perineum, perianal region, and external genitalia. When you find this, surgery is the first line of treatment along with antimicrobial therapy. Immediate surgical debridement is mandatory within 24 hours of presentation, or else the patient might succumb also. Okay, it is a very important surgical indication for a complicated UTI. Okay, so this completes our UTI urosepsis. I hope you understand what is complicated and uncomplicated. Your questions for the examination will be from the complicated UTI, but as the definitions have come in 2025, one released in July, one released in March, and one released in recent June. So just go through the guidelines once and know the definitions properly, and just know what is different from the old definition, and definitely go through the pyelonephritis, emphysematous pyelonephritis, and UTI in men. Okay, these slides are more than enough for your exams to write a 5-mark question or a sub questions of 10 mark. Okay, thank you for joining the class. Bhageshri, you can stop recording.